I'd be happy to. This is a multi-center study looking at the problem of cognitive motor dissociation in patients with disorders of consciousness. This is a problem that was recognized over the last 20 years, roughly, that some patients who appear to be in vegetative state, minimally conscious state minus, where they don't respond to verbal commands, or even coma, in more recent studies, retain a high level of cognitive capacity to do sustained mental work, as evidenced by performance of complex cognitive tasks on fMRI or EEG platforms, essentially, for neuroimaging and electrophysiology testing. And so the study was an attempt to take an estimate in a accumulated convenience sample collected, in this case, in 6 centers around the world, in the US, Canada, Belgium, Cambridge, England, and the University of Paris in France, to get a sense of what is the number that we would come up with of patients who appear to be unresponsive to commands, who nonetheless are able to do these high-level tasks. And the main finding of the study is that we found this commonly in about 25% of those who were unresponsive to command. We also looked at a comparable group of patients with disorders of consciousness who did show bedside command following, most of whom did not also show signs of accurate communication, but they were what we would call minimally conscious plus. Some of them were further advanced than that. And the majority of those patients were also unable to do this task. So it helps calibrate the difficulty of what it is we're actually trying to have the subjects do in the study. And it underscores, I think, the meaning of people who are appearing to be in coma, vegetative state, minimally conscious minus, who are retaining this capacity to carry out this cognitive work. Those are the main points. So I think there are 2 main kinds of implications of this work. The most important one is the diagnostic discernment implication. But we've known for a long time that the very careful clinical examination of patients with severe brain injury and a disorder of consciousness can be tricky. It can hide the distinctions between minimally conscious state and vegetative state, which early on in the recovery process have a big prognostic difference. This study was mostly done in chronic disorders of consciousness. The median time for the chronic cohort, which was 75% of the sample, was at 8 months after their injury. But 25% of this sample did come from the acute setting, and the overall finding is basically uniform. I think what this means is that we need to have infrastructure developed pretty much everywhere to make accurate diagnoses available and to build these tools out of the research setting into some things that can be done clinically, probably do sample enrichment to then bring people to assessment with this set of tools. These tools are not particularly sensitive to awareness. They are sensitive to this sharp dissociation between high-level cognitive function and no evidence of it at the bedside. But the other thing that I think that this really points to is the need to start having demonstration projects to test the widely tested technologies of brain-computer interfaces that have been used that have high performance characteristics. Those are implantable systems, typically intracortical. They've been doing amazing things for the last 10 years or more. There's another study in the current issue of the New England Journal of Medicine that shows the next state of the art. These are tools that we could try to apply to patients with cognitive motor dissociation. We have every reason to believe that some of them will harness them, because we've seen some of these patients over time emerge to have a motor system, gesture to communicate with, or some of them even develop speech late, years into their recovery. And we've seen that they, once they're able to communicate fluently, have retained, not baseline, but near baseline cognitive capacity. So I think what we want to do is build a science of this. And if you know that this is a conservative estimate that we're publishing for a lot of reasons, we geared the statistics in all of the assessment centers to be very stringent. to basically remove false positives. So there are false negatives. We know that. We didn't concern ourselves with that. We wanted to get a conservative estimate. The other thing that the results show is that when patients were evaluated by both fMRI and EEG, when they had both tests, our detection rate was higher. So, you know, that's a lower bound. There are plenty of people out there for us to try to find, build this kind of work forward, and create a science of trying to restore their connection. That's basically the picture I would have.